We were discussing ulcerative colitis, how we can grade it. We'll go for that. We have seen various signs, symptoms. So on that basis, when we make it accordingly, the symptoms we can have mild, severe and moderate. So how many bowel movements per day, or how many how many times the person is having these bowel movements. These are when it is less than 4, we'll call it as mild, 4 to 6 moderate, more than that. And one of the feature which is having systemic upset, we shall see what is systemic upset, then we'll call it as a severe. Then blood in stool, not more than small amount. In moderate it is mild and severe, and visible blood is there in stool, that is the severe condition. Pyrexia, that is increase in the body temperature, only in severe it is increased, while in moderate and mild it is not there. Pulse rate is increased in severe only. Pulse rate is greater than, that is anemia is there because of blood loss in severe one. The erythrocyte sedimentation rate is around 30 in mild and moderate, while in severe it is above 30. So these are the conditions. Apart from that, in addition to that, these are abdominal pain. The scores are there, that is in children particularly. Abdominal pain, pain can be ignored, pain cannot be ignored, rectal bleeding, stool consistency, then number of stools per hour. These are all various conditions. On that basis the scores are developed. Then nocturnal stills, that which is causing awakening, the disturbing sleep. So these are the various parameters on the basis the mild, moderate, severe is there, and accordingly it helps us in the treatment. Now what we should go for the treatment. So when a person is there with first presentation, in that what we can do, and this proctitis, that is inflammation to rectum, is mild to moderate. Then in that cases what we will go is give the aminosalicylates or topical or this oral corticosteroids, which we can give. Then next is proctosigmoides, that is left-sided ulcerative colitis, that is mild to moderate. If the remission is not achieved within 4 weeks, then we'll go for high dose of aminosalicylate and switching to high dose oral aminosalicylate in addition to topical aminosalicylates. And if needed, then we can go for oral corticosteroids. Who are having this topical treatment, there is a remission or there is a reduction, then high dose of aminosalicylate alone will be sufficient. No need to give steroids in this patient. However, if it is not achieved, then we have to add corticosteroids. Then extensive ulcerative colitis, where it is mild to moderate, it is there. Then in that cases, the doses may be too high, that aminosalicylates can be tolerated. So aminosalicylate up to tolerable dose only can be given, and then oral corticosteroids can be given. Then if there is acute severe ulcerative colitis, what we can go for. So in that cases, usually we have the newer agents. If you have seen all these these monoclonal antibodies, or those which are having a newer one, that is tyrosine kinase activities. So these can be used, and depending on all these these conditions, that is stool frequency, pyrexia, body temperature, that is tachycardia, ESR, etc., X-rays, we can go for the treatment. Here we have to give intravenous corticosteroids for induction remission. Then if it is there, assess the likelihood of the person who will need surgery, that much portion can be removed. Intravenous cyclosporin, it is an immunosuppressant or surgery for the people who cannot tolerate or who decline intravenous corticosteroids, or for whom treatment with the intravenous corticosteroid is contraindicated. In that patient we cannot give. Consider the adding intravenous cyclosporin into intravenous corticosteroid or surgery in these severe people who are having. Then newer agents, I told you, monoclonal antibodies like infliximab can be given. And apart from infliximab, there are many new these monoclonal antibodies are there. Some of these are under clinical trials. We have discussed this all in our earlier class. So these can be used for this. Then surgery, I told you that much portion is removed. Then treatment for this moderate to severe ulcerative colitis, what we are going to do. In that cases, again these various monoclonal antibodies like ustekinumab can be used. That is, it is a monoclonal antibody. Then this TNF alpha inhibitors like etanercept and many other newer agents are there which are antagonizing TNF alpha, but they are not having that benefit which was expected, and they cannot be tolerated and it is not suitable. Then ustekinumab is the better one, the better analog in that cases. Then tofacitinib, I told you this is a tyrosine kinase. NIBs are the tyrosine kinase inhibitors. So it is recommended, again being a new agent, the word comes marketing authorization. That means it is the treatment is done under complete observation. So this is the treatment that can be given in that case. This is called as a these are called as a biological agents. Then vedolizumab, this is again another newer antibodies, that is monoclonal antibodies which are there. Then vedolizumab should be given until it stops working or surgery is needed. Till that period we can give it. Then next is the agent, that is infliximab, adalimumab and golimumab. So these are the again agents which can be recommended within their marketing authorizations as treating moderate to severe active ulcerative colitis in the adults whose disease has responded inadequately to the conventional therapy including corticosteroids. Golimumab is recommended only if the these are particularly related to the this topic. Actually you will have in 5th year, we call it as a pharmacoeconomics. Particularly insurance companies, they consider this, that the cost should not be very high, that at the same cost as the 50 mg dose as agreed in the patient access scheme. These are the schemes are there. Particularly these are applicable in various foreign countries where most of the cost is borne by the insurance companies, and therefore these insurance companies, they wish that unnecessarily higher cost medication should not be used, and then they should make the economics easy comparatively. So choice of treatment between infliximab, adalimumab and golimumab should be made on the individual basis after discussion between the responsible clinician and the patient about the advantages, disadvantages, and also consider the need and whether the patient is likely to adhere the treatment. If more than one treatment is suitable, then at least expensive should be chosen, taken into account administration cost, doses and price per dose. This is again what we call it as a pharmacoeconomics. So these are the drugs which should be continued for 12 months, or if the surgery is required, till the surgery is there. If there is a remission with this drug, then surgery can be avoided, and discuss the risk and benefit of the continued treatment with the patient and the parent or carer, whosoever is there with them, it should be discussed. Then there is few more agents are there like Remsima, that is infliximab biosimilar. This is given, biosimilar means which is having similar activity to that, and it can be given for subcutaneous use. Budesonide is a corticosteroid and it can be given as a budesonide multimatrix. It can be given. So this is how the ulcerative colitis can be treated. These are the treatment guidelines, treatment what we can say flow charts for that. So how this treatment can be there into this. Then we can have the maintenance treatment. A topical aminosalicylate alone can be given, particularly in mild to moderate cases. Oral aminosalicylate plus topical aminosalicylate can be given daily or intermittently, depending on the conditions. If it is a left side or extensive ulcerative colitis, then in that cases, what we can do is a low maintenance dose of oral aminosalicylate can be given. Oral aminosalicylate to use take in account the person's preference, side effect and cost, then oral aminosalicylate can be selected. These are various mesalazine and various aminosalicylate are there. So out of that, usually mesalazine is used. Mesalazine is used, then maintain the remission in children and young people in moderate to mild to moderate inflammatory exacerbations. So aminosalicylate is particularly continued. If required, then we can go intermittently azathioprine or mercaptopurine. These are all immunosuppressant agents. So after 2 or more inflammatory exacerbation in 12 months that require treatment with the systemic corticosteroids, or if remission is not maintained by aminosalicylate, then we go for this immunosuppressant like azathioprine or oral mercaptopurines. Aminosalicylates or azathioprine, mercaptopurine are contraindicated in the person in that if the azathioprine or mercaptopurine are not allowed or they are contraindicated, then again we have to switch to aminosalicylates only, because aminosalicylates are comparatively safer than other agents, and therefore they are only thing is they are not as effective as other cases, and therefore they can be only useful till mild and moderate. Beyond that, they are having little utility. Consider once a daily dose regimen for oral aminosalicylates when used for maintaining remissions. Take account of person's preference and accordingly the best dosages can be given. Then leukapheresis is the treatment that is done in conditions which are severe, which involves the extracorporeal removal of leukocytes from the blood, because we have seen that it is the overacting of this immune mechanism, and by centrifugation or by passage of blood through an adsorptive system, the venous blood is removed in a continuous flow, anticoagulated, processed to deplete leukocytes, and it is returned to the circulation. So this takes approximately 1 to 2 hours, and it is carried out once or twice a week for 5 to 10 sessions. So in that cases, this is used. Then how we can monitor the treatment? Monitoring the bone health, growth and pubertal development, particularly if the children are there. Because we have seen that these people are having problems with nutrition and therefore growth and therefore overall development. So check various things whether the because of that growth which was retarded, pivotal development was retarded, whether it has been initiated back or not. Then monitoring the bone health, and then go for the other activities like pivotal growth we have seen, then go for various growth parameters, and the parameters for healthiness, that is whether there is anemia or something like that. So all these things should be monitored. Bone health should be monitored. That is, consider the monitoring bone health in children, young people during chronic disease, after the treatment with the systemic corticosteroids, and after recurrence of the disease, because bone health is also affected in these people. So the fragility of fracture or the bone density tests are there, they should be done in these patients. So this is how ulcerative colitis can be treated. We can have a fast glimpse on the exact or detailed guideline for this Crohn's disease also. So let us see what are the treatment which are there for Crohn's disease. So Crohn's disease, we have seen again diagnostic and prognostic tests we can have. How we'll categorizing it, what are the tests. We have seen various tests earlier, particularly fecal calprotectin test, which will guide about it. Just hello, hello, sir. Yes sir. जी सर, जी सर, क्लास ले रहा था मैं. हाँ हाँ हाँ, मैं कर ले जी. अच्छा सर, मैं आता हूँ ना सर, मैं नीचे आता हूँ थोड़ी देर. चलो मैं थोड़ा नीचे आता हूँ सर, तो आता हूँ नीचे, बात करते हैं. ओके. यस प्रतिमा, ये हेलो. हाँ प्रतिमा.